Hi, good afternoon, everyone. My name is Dr. Dominic Akateba. I'm a physician specialist and I'm with Ghana Medical Help. Thank you for joining us for this afternoon's presentation on labor ward management. It's part of our maternity service agenda as Ghana Medical Help towards helping to improve upon maternal health delivery as well as neonatal newborn care. We started these webinars 2 years ago. This year we started off in January, took a pause somewhere along the year, and we are resuming today with a presentation on labor ward management. Kindly join me in welcoming Dr. Theophilus Ben Sabi. Dr. Theophilus is an obstetrician gynecologist, a member of the Ghana College of Physicians and Surgeons, and he's been with us in the Upper West for a long while and practices elsewhere now. We are glad that he could make time out of his busy schedule to take us through this webinar. Just a few household keeping rules that you may have noticed, and I would wish to prompt you to them. If you try unmuting yourself, you won't be able to. This is to prevent people from inadvertently unmuting themselves. As well, if you try turning on your video, you will not be able to. Also to help with the bandwidth, especially for those of us who are in rural environments. Kindly bear with us with that. However, whilst the presentation is going on, the chat box is open. Kindly make use of it. And then at the end of his presentation, which we are hoping will take 35 minutes maximum, we would have some time to have a discussion around it. So kindly stick and stay, and I'm sure you would enjoy this legendary presentation from Dr. Sabi Theophilus. Dr. Sabi, over to you, sir.
Okay, thank you very much, Dr. Dominic Akatiba. I hope everyone can hear me.
Yes, you are loud and clear.
Okay. So I'll be presenting on labor ward management. I hope that it will be as interactive as possible. I have just like a few questions that you can answer in the chat box. So feel free to just post your answers, or if you have any questions, you can also post them in the chat box. Okay, hope my slides are moving.
Unfortunately not. It's on the first slide.
Okay. Okay. I think I'll need to stop sharing and then share again.
Okay,
For some reason.
sure.
Okay, is it moving?
Yes, it does now. Yeah.
Okay, all right. So I have nothing to declare. I have no conflicts of interest. My aim today is just...
Sorry, Dr. Sabi, could you kindly put it on slide full screen mode?
Yeah. Is it clear?
Great. All right. Sure.
Yeah.
Thank you. It is.
Okay. So my aim today is just to help you see and approach the labor ward differently. I know we've had different sessions on this webinar, so I'm not going to go into management of cases per se, but just a way to approach the labor ward differently. And this will be the outline. We'll talk about the labor ward, the chaos, speak about working in teams, and what we mean by helicopter view, how we should act, and then the traffic light system and how to take control of the chaos. I'll start off with this story that happened to me. So just some few weeks ago, I took a patient to the theater just to remove, do a manual removal of placenta. And after I removed the placenta, the patient was bleeding. I started uterine massage. We gave some uterotonics, and the uterus, wasn't very well contracted. So I continued doing uterine massage. I got to a time my hands became a bit numb, and the assistant noticed it. And so, she prompted me if I was okay. I said, well, I'm a bit tired in my hands, so I need a uterine massage. And the assistant spoke to the floating midwife and said, Tio needs a massage. And this midwife was like confused. She wore gloves. I was, fully sterile. And she was a bit slow to act. She came to stand beside me and she wore gloves and she was like just thinking, and you could see that she was thinking. And then that's when we all realized and everybody started laughing. And she was contemplating how to break the sterile field to actually give me a massage. And this story is, quite funny because it just tells us how communication is important. And so how we communicate in the labor ward determines the kind of results that we get. Chaos happens, and it's said that life is nothing without a little chaos to make it interesting. And the question is, do we need chaos on the labor ward? If you are someone who is early in your career, probably even like a midwifery student or a junior doctor, house officer, you would want a bit of action. The midwife student has the number of deliveries they need to attain. And so when they come on the shift, they want there to be deliveries, whilst the more experienced person just wants to come and have a very calm shift and then go back home. And chaos inevitably would happen. It's how we act, how we reduce it, and how we approach it that is important. And I've worked in a number of hospitals. Generally, if you are very observant and you've also worked in a labor ward, you realize that there are certain people, when they're on the labor ward, it's quite stressful, it's messy, and there's always seems to be a lot going on. There are other people too, when they're on the labor ward, it's quite calm. Even though there may be emergencies, it's more structured, there's more organization, there's more control. And that is where I want to sort of shift your mind towards. Generally, the labor ward has this structure. You can have a consultant or a matron, or whoever is in charge of the labor ward. And you have junior doctors and then the other midwifery staff plus patients. The overall responsibility of the patients usually lies with the consultant. And we have other people who also contribute as well, like the laboratory staff, the healthcare assistants. Why is it important to know your team, right? Every day we have different people coming onto the labor ward. We have different staff, people come and go. And on every shift, it's important to know who your team members are. It's important to know them by their names. This is important because during emergencies, you don't want to be fumbling. You don't want to call for Mary, who is the student, instead of Mary, who is a midwife, or Mary, who is a house officer, instead of Mary, who is a specialist, right? You should be able to identify each team member by who they are. Prime example, those of you who like movies, there's been 3 different people who've actually acted Spider-Man like over the past 20-30 years. And even though they all are called Spider-Man, they all have certain subtle differences. The one on the left is more sharper, he's faster. The one on the right is just more durable, he's quite strong. That doesn't mean all of them are not strong. They are all strong, but that is his specialty. He's just more strong than the rest. The one in the middle is able to adapt technology and use it to his advantage. And so it's important we know what the competence of everyone in the labor world is. What can each person do? What are they comfortable in doing? Because it's competence that determines what you are going to assign to each member. When you think about it, what happens to us during high-risk emergencies? Adrenaline takes over and it becomes difficult to respond. But if you have a set structure, then you can respond appropriately. It's also important to know where your team members are at every point in time. Those of everyone working on the labor ward. Why is this important? Every minute you have more than 500 mils of blood flow into the uterus. That should give you an idea how things can escalate on the labor ward. So where are your team members? How far are they? And you should let the overall supervisor know exactly where you are going at each point in time. This is a famous corridor. It's a corridor of a hospital in Wales, and it's said to be the longest corridor in the world. It's about 1 kilometer long. Imagine having a doctor on duty who is on the other end of this corridor. I should tell you that it's going to take a while for him to attend to that emergency. And it's important that if this doctor is going to go to the other end, he lets everyone on the team know where exactly he's going to. This is a question that you can all feel free to answer on the chat box. I'll give you some time. And you can just answer A, B, or C. So it's a scenario. In a shoulder dystocia, who are you calling first? So A, there's a house officer who just graduated medical school, who started 3 days ago in your unit. There's a consultant or specialist who is currently off-site. Off-site meaning he's probably at home, maybe 30 minutes or 1 hour away. And then there's the resident or medical officer who is on-site and has been working in the department for 2 years. You can all feel free to post your answers in the chat box. I'll just give a few seconds. I'm not able to see the chat box because of the presentation, so I hope that there are some answers there.
Yeah, they are. Anytime you want me to read them to you, I'm happy to do that.
Yeah, you can. You can read them.
Okay. So we have the first one as C. I think option C. You have another one as the resident or MO on site. I think that should also be option C.
Yeah.
So 2 responses so far, both saying C, the resident or the MO on site.
Okay. So if you're thinking C or you answer C, then you are right. Obviously, the house officer just completed. He probably hasn't seen a shoulder dystocia before, he or she. And in that emergency, I'm not sure how he's going to respond. The consultant is currently not on site. He's very far away. You have the resident medical officer who's basically seen it all and is currently on site. And so the correct answer is C. This gives us a blend of what each person can do, applying what each person can do and where exactly they are. I'm going to play this short video. Again, feel free to post your answers on the chat box. It says count how many times players wearing white pass the basketball. So you are going to see a number of players, some in white, some in black. They will be passing basketball. Each team will be passing a basketball. So So just count how many times those in white pass the basketball.
The players wearing white pass the basketball. How many passes did
So how many passes do you count? You can post it on the chat box. And Dr. Dominic, if there are any answers, you can just read them for me.
Sure. No answers thus far. I'll just wait for the answers and then I'll read them out.
Okay. So I'll just play the video.
you count? The correct answer is 15 passes. But did you see the gorilla?
We had a couple of responses, which also gave about 13. There's an 8.
Okay.
There's a 15.
Okay.
There's a 14 as well.
Okay. So the idea is not actually to get the correct number. Those who did done well. But there's another question. Did you actually see the gorilla? Okay, I hope you saw the gorilla now. And I'm going to introduce another sort of principle, what we call situational awareness or helicopter view. It's just reiterates the fact that focus is important, focus is good, because it's by focusing on how many times the white players count through the ball that you're able to get a number. So focus helps to achieve a goal. However, focus can also be detrimental, right? Because you were so focused, I'm sure there will be some people who didn't see the gorilla. The first time I actually watched this video, I actually didn't see the gorilla. Okay. So, helicopter view or situational awareness. There's a case that happened in 2007. It's concerning the woman on the left. She's called Ellen Bromley. She had recurrent sinus infections. She was happily married with 2 children. And she went to see an ENT specialist, and they recommended surgery. Sinus operations are quite simple, they are not very complex surgeries. And so on the day of the surgery, she went in happy, excited. And the plan was made for a general anesthesia. So the anesthetist planned to put in what we call a laryngeal mask airway. And it's a bit different from an endotracheal tube. And during anesthesia, if you know anything about anesthesia, you know that usually we need to paralyze the diaphragm so that the patient can't breathe. We pass a tube and then we use a machine to help the patient to breathe. So the anesthetist paralyzed the diaphragm, tried passing the laryngeal mask airway, and there was difficulty. The anesthetist couldn't pass the laryngeal mask airway, and he straight away switched to an endotracheal tube, and again attempted, tried and tried and tried and tried and tried. And it took about 25 minutes before the anesthetist would pass the endotracheal tube, by which time Elaine had suffered a brain injury, and she eventually passed away about 13 days afterwards. What was meant to be a simple sinus surgery ended up in her losing her life. There were other ways to secure the airway. Obviously, the main learning point is situational awareness. The anesthetist was very focused and was hell-bent on, getting this tube in, without realizing that this patient had very low saturations, about 40% for about 25 minutes. There were other theater staff around who tried to sort of alert, the anesthetist, but they were just too focused. And just another example that happened to me a couple of weeks ago. Came on a shift to labor ward. Patient has been pushing for some time, baby not coming. Plan has been made for her to go into theater for some sort of instrumental delivery. She had an epidural on board. She went into theater. Anesthetist has decided take out the epidural and then put in a spinal. Obviously, I hadn't seen the other patients on the labor ward yet. Once the patient was in theater, I went into another labor room to see what was going on. I realized that this baby's heart rate, whilst on the monitor, had gone up. A high heart rate just points to a number of things. Is there meconium? Is there infection? Is there choreo? Is there dehydration? This woman had chorioamnionitis. Just some few minutes afterwards, the baby started deceleration. With babies who have choreo with decelerations, there's a risk that they are going to aspirate this, who have meconium with decelerations, there's a risk that they are going to aspirate this meconium and the baby would, end up having some sort of brain injury. So made a decision that this patient definitely needs a delivery, and she trumps the other patient because the other patient who was already in theater, the baby was quite normal on the monitor. But at that time, the epidural had already been taken out. And so we had to leave this woman in pain, went in to do the other case, came back, and then eventually delivered this woman. Some weeks later, this woman put in a complaint that she was left in an inhumane manner and in pain and without proper analgesia. And this simple complication that happened could have been prevented if there was good situational awareness of what was happening on the labor ward. When you're trying to communicate, there's 3 things you want to ask. Am I calling to seek advice? Am I calling to inform? Am I calling to ask the person to do something? I'm going to put 2 scenarios there. The first one, a woman has come in. So this is someone communicating in an emergency. A woman has come in bleeding. She's unstable. What are some of the things you'd want to know about this woman? Okay, if someone called you in or someone spoke to you that this is a case, obviously this is very incomplete. There are a number of things you'd want to know. Is this patient even pregnant at all? What are her vital signs? How many weeks is she? Compared to this, which says, I need you to come in. A woman has come in with heavy bleeding and passing clots. She's 38 weeks. She's a known hypertensive. Her blood pressure is 70/40. Her heart rate is 120 beats per minute. We've taken some blood and started fluids. This is quite clear. This is quite distinct. Immediately gives you even differentials to think about. Someone who is bleeding, known hypertensive, the first thing you think about is an abruption. Okay, so this introduces the third, another principle, what we call the S-bar, that should help you to communicate. So what's the situation you are dealing with? The woman is bleeding. What's the background of the woman? She's 38 weeks. She's a known preeclampsia, or she's a known hypertensive. What was your assessment? Her blood pressure is this, her pulse is this, the baby's heart rate is this. And what have we done so far? Okay. How do you respond in an emergency? There's 4 questions. And you can put your answers in the chat box. Is it better to walk casually, to walk briskly, to run? or helicopter view first? You can put your answers in the chat box. How do you respond in an emergency? Is it better to walk casually, to walk briskly, to run, or helicopter view first? I don't know if there are any answers in the chat box.
Not yet.
Okay.
I'm on the lookout. When they're in there, I'll read them out.
Okay, so the different options sort of in a way gives you an idea as to people's tolerance level, people's experience levels. There's no research to say, it's better to do this or to do that. I've spoken to quite a number of experienced people or work with quite a number of experienced people, and you never see someone who's experienced run towards an emergency. I mean, from my own experience and from working with people, generally they tend to walk briskly. And the other thing to also take note is having a helicopter view. So, I mean, to this, the first response would be what is happening around you. Okay. So having a good situational awareness of everything that's happening around you. Because as we discussed earlier, once you become focused in a particular situation, it sort of distorts your awareness. Imagine a patient on the labor ward, maybe twin pregnancy, 6 centimeters. Obviously, with this twin pregnancy, you need an experienced person to deliver. And then there's a woman who needs to go to theater because of a failure to progress. Right. So what we are saying is, before you take that woman to theater, it's important you know what's happening with a twin lady. Okay. Has she just had an ARM? Has she just ruptured membrane spontaneously? Is she fully dilated now? If you found out she was fully dilated, would that change how you approach sending the other failure to progress to theater? I'm sure we've all come to a junction where there's been no traffic light and the chaos there. However, if there was traffic light, then everything is just orderly, right? I introduced another principle. Before that, there's another question on board. With these situations, who are you prioritizing first? So you can put your answers in the chat box again. Who are you prioritizing first? So just sort of first to last. So there's a failure to progress as A. There's an unstable placental abruption with heavy bleeding as B. There's a severe preeclampsia as C. And there's a fetal bradycardia as D. So you can just sort of post your answers, who you are prioritizing from first to last. So there's a failure to progress.
Couple of answers have come in. So there's D, which is a fetal bradycardia from Solomon. Monira 2 says B.
Yeah.
Jenny says C. So
Okay.
these are what's in the chat box.
Okay. Right.
And then Hadi has prioritized. He says B first, followed by D, and then A and C last. A couple more. Peter says B, D, C, and A. And Notias says C, B, D, and A.
Okay. Right. Okay. So that's fine. So generally, when you're trying to prioritize, you want to look at the mother first. Mother always first. Is there any life-threatening situation here? that can pose a risk to the mother? If you answered B first, then you are most likely right. And is the next thing you want to ask yourself is there any life-threatening situation here that is immediately putting the baby at risk? So a life-threatening situation immediately putting the mother at risk. A life-threatening situation immediately putting the baby at risk. And the next one is there any urgent situation putting the mother at risk? Is there any urgent situation putting the baby at risk? Right. Obviously, the placental abruption with heavy bleeding would kill the mother first. The fetal bradycardia would also kill the baby next. They will both kill, each other, but because the mother trumps the baby, you'd go with B first, then you go with D. You need to deliver the baby within 15 minutes for the fetal body. Then you have a failure to progress and then a severe preeclampsia. Obviously, the severe preeclampsia needs to go next. You might not necessarily need to deliver now, but it's quite urgent. It poses a risk to the mother. And then you have a failure to progress as coming last. So that introduces the red, gold, green to help you just see which patients are more urgent that you need to attend, which patients are semi-urgent, and which patients you can wait on. A couple more questions. Who are you assigning to each case? So you have a specialist or medical officer, you have a house officer, you have a midwife. You have a specialist or medical officer, just leave it as specialist. You have a house officer, you have a midwife. So the cases are eclampsia, A, B. B is multiple in spontaneous labor, and then C, diarrhea and vomiting in pregnancy. So you have three people, a specialist, a house officer, a midwife. Who are you assigning to each case? A, you have an eclampsia. B, you have a multiple in spontaneous labor. C, you have diarrhea and vomiting in pregnancy.
All right, so we have a couple of answers from the chat box. So Yvonne says eclampsia to the specialist, multiple to the midwife, diarrhea to the HO. Thelma, A, specialist, B, midwife, C, house officer. I'm here, A, specialist, B, midwife, and then the C, HO. Then Martha says yes. Yeah, so Martha, B, midwife, C, house officer, and then case A to the MO. And Monira to MO, midwife. Then Daniel Bagman, A to the specialist or medical officer, B to the midwife, C to the house officer. And iPhone says B to the midwife. Jenny says A for the specialist, B for the midwife, C for the house officer. Stephen says A to the specialist, B midwife, C HO. Techno, A specialist, B midwife, C house officer. Chairman eclampsia to the specialist, diarrhea, vomiting, MO, and then the multiple to the midwife.
Okay.
Elizabeth, A specialist, fine. B midwife. You good? All right.
Okay.
Over.
So I think most people had it right. Just to reiterate the point of knowing what the competence of each person is and what they can manage. So how do you take control of the chaos? This is the last bit I'll be speaking about. Just try and anticipate risk and then try and reduce risk. That's basically what you need to do. So you're asking yourself, what's the worst that could happen? You have a patient with a high head, a multiple, and she needs basically an AR. So you need to ask yourself, what could happen with this? We're thinking about cord prolapse. Okay. So should you do this ARM in the room with how high the baby's head is, knowing that there's a risk of cord prolapse? Is there another alternative, or can you do it differently? Can you do it in theater, if there's theater space? Or can you get someone to give you some fundal pressure to help the head to engage whilst you break the waters? And this brings back to the point of some people being on the labor ward and having, always sort of stressful cases, or the labor ward always being very busy and chaotic, right? So the one who thinks through this would do it differently and wouldn't just go and just do an ARM just because his patient needs an ARM. Okay. You're about to do a manual removal of placenta in the room. Okay, is there another alternative? Have you anticipated what could happen? There's risk of bleeding. Does this patient has an IV access? Or are you waiting for the patient to start bleeding before you put in a line? Before grouping and screening is taken to theater? Right, there's a ground multip who needs an induction. All your staff are preoccupied with emergencies. Is there another alternative? Do you need to start this induction right now? Or can you wait a bit for some of the emergencies to be managed before you go ahead, knowing that with this ground multip, there's a risk that she could progress faster. There's a risk that she could have a PPH afterwards. So that's the end. I hope we're able to achieve the main aim that I set out to do. This is a feedback form that you can give feedback on this session. I would place the link in the WhatsApp group so you can give some feedback. And if there are any questions, they are welcome.
Great, excellent, Dr. Sabi. This has been extremely interactive, and I'm sure lots of us have learned a lot of good things towards keeping our pregnant women alive and healthy with newborns. We open the floor for questions. If you have a question to ask, two ways. You could use the chat box to type in your question. However, we'll be even more happy to hear your voice. So you could electronically put up your hand instead of using the chat box, and I'll be glad to unmute you to ask your question. The last comment that came in the chat box just before you signed off, Sabi, was that they wanted to know which was the right answer to the last question you put up.
The last question?
Yeah, assigning to which specialty or to which personnel?
Oh, yeah, the specialist or the MO to the eclampsia. The house officer definitely to the diarrhea and vomiting. And then the midwife takes the multip. That's their bread and butter. It's labor.
Fantastic. Great. So guys, kindly electronically put up your hand, and I'll be glad to ask you to unmute to go ahead with your comment, contribution, or question. We are glad when we hear your voice. We are happy when you make contributions, because it just makes it more practical and helps to shape the discourse. So don't feel shy. Kindly electronically raise up your hand, and I'll give you the go. Great. Munira, please go ahead.
Yes, Doc. Please, where you ask the question, the assignment of the cases or conditions to the appropriate health workers. No, I want to ask, we those at the villages or polyclinics, sometimes most of our doctors are not around. Can we chip in or help with the work of maybe the MO that is not around in some cases? Thank you.
Right. Definitely you can. And it goes back to the the S-bar that we spoke about. What's the situation? What's the background of the patient? What's your assessment? What's the recommendation? So, I mean, patient has come in with diarrhea and vomiting. The patient needs some fluids. You're not going to wait for the house officer maybe to set a line if it's something you can do to help stabilize. So there's an initial stabilization. Even with the eclampsia, you probably have seen it, you know how to manage it. Okay, but definitely they will still need to be seen by somebody to make a decision as to what to do. So having an initial management, yes, you can. And I understand the barriers in certain parts of Ghana. So putting in emergency interventions is definitely something that you need to do. Okay. And if you can manage, if you have found yourself alone there and there's no one, what can you do? There was a time when I was working as a medical officer, a colleague medical officer referred an antepartum hemorrhage to me, and the person was, needed surgery. Immediately we went in. This patient had a uterine rupture. Okay, how am I going to deal with this? I haven't done hysterectomy before. But this is where I find myself. So sometimes you can't help it. You have to do something to help the patient. That's a different scenario. But if you have everyone available to you, then you should try and then make good use of them. Yeah.
Great. Thank you for that insight. So Jenny is next. But Jenny, just before you ask your question or pass your comment, kindly go with me to the chat box. I've just put up some information there. So you could like our Facebook page or our LinkedIn page for updates on the topics for our weekly presentations. So just like this one, it's usually advertised on our social media handles. So if you want to be informed about what's next, what presentation is next, just follow those links. So those who do Facebook, you can. Those who do LinkedIn, then you can follow that link to like our handles. As well, this webinar, as well as all our previous webinars, are usually recorded. So you realize that we're recording this. So we usually put them up on our YouTube channel, Ghana Medical Help. I've put the link as well in the chat box. So those who may have joined late or with network issues, you'll find that this will be put in there. You could download it, you could listen to it in the comfort of your room at any time that you have network permitting. So kindly take note of these. These have been put in the chat box. The links have been put in there. You can go ahead and then make use of it. So Jenny, kindly go ahead with your question. I've asked you to unmute yourself. Hi, Jenny. Hi, Jenny, your hand is up. You could go ahead to unmute yourself.
Okay, Doc, my question. Okay, please. My question is, can we also consider the willingness of the person, whether the person is willing to work? Maybe the person is capable, but will not be willing to work at that moment. Can we also consider that?
I don't quite get your question, but if you are being paid to work, then you need to work. I don't think you can just stand up and say you don't want to work. But that's not a good attitude to approach your work. So for such a person, I don't know what to say to such a person if you just stand up and say you don't want to work anyway. Yeah.
Yeah, and there's a question in the chat box from Peter Derry. Says, please, where there is an existing protocol in managing certain conditions in the facility, can the available health worker trained in such area act immediately while seeking help?
Yes.
I don't know.
Yes.
Yeah. Okay. Go ahead.
That's very important. Protocols are there. There are sort of systems put in place so that everybody will be able to follow it. And if you have a protocol that states, initial management or what you can do in that instance, yes, you need to, do it. And I know there are variations in practice. Someone practicing in a small district hospital will be quite different from someone practicing in a teaching hospital. So there will be variations in how we approach cases. So if you have protocols that you need to go by, you just need to go by them. The important thing is to save the patient's life.
Great. Jenny, your hand is still up. Is it a legacy hand? Or you want to follow up on your question? Okay, all right. She's dropped it. Any more questions? Kindly electronically raise up your hand and I'll be glad to unmute you so that we hear your wonderful voice. Anyone with any question, any comments? Kindly put up your hand and I will unmute you. Don't feel shy. Let's make this interactive. We have about 30 minutes to the top of the hour, so we have good time. Feel free to put up your hand and I'll mute you. Any contribution from anyone? I see a couple of the gynecologists have also joined. Feel free to make an input. Chat box. Yeah, so a couple of comments in the chat box from Salam. Says, thank you, Doc, for the presentation. With regard to the role assignment, eclampsia being an obstetric emergency, shouldn't the consultant or specialist, HO and midwife all attend to it first? Hi, Dr. Sabi. Did you hear that? I think the microphone is muted.
Yeah, hello.
Yeah, great.
Yeah, that's an interesting perspective. So, yes, it's an emergency. And if all of them, happen at the same time, definitely they would all need to attend the eclampsia because you need more people by the looks of things, But it wasn't it was just to test your ability to know who or what the appropriate person is that you need to call or that you need to escalate to. So it wasn't a test of sort of managing the actual eclampsia. With the actual eclampsia, it will be difficult for one person to actually manage it. So you need people, but it was just to test your ability to assign people, to know what the competency of your staff is and who you need to call in those cases and who you need to escalate to.
Great.
And again,
yeah, go ahead.
Again, it depends on where you are working. I know there are some facilities that wouldn't have like a specialist or a consultant, so it wouldn't apply in those instances.
Legendary. Yeah. So next is Anita. Anita, please go ahead and ask your question or make your contribution. Hi, Anita Asarik. I've asked you to unmute yourself. Could you kindly go ahead?
Okay. Please, my question is, we also working at the prison. Sometimes we don't even have what it takes to manage a case that comes to the facility. So when you call your next level to refer the case, then they tell you there's no doctor. Meanwhile, they have been working with doctors and they have what it takes to manage the client, even in the absence of the doctor. There's sometimes when you call your next level to refer a case like that, then they tell you there's no doctor and you be stranded with the case. You don't know what to do. You don't even have what it takes to manage the case. Knowing very well that your next level, they have what it takes to manage the case, but they refuse it, your referral. So what do you do? Thank you.
Yeah. I'm sure there will be a lot of, challenges that would probably be beyond the scope of this meeting. But I know Dr. Dominic and his team are doing quite well to help some of the facilities. And so, that's the whole idea of this presentation. One of the things is to be able to anticipate so that you don't put yourself in a situation where you are not able to manage, or you don't have the facilities to manage. I know there'll be instances where you can't help it. Patients will come. If patients have decided they will come, they will come. So there's not much you can do. But if referral is difficult, then in those instances, you have to do what you can to help the patient. But it should be very clear. Referral processes are totally different. It should be very clear where you can refer to, and facilities should be willing to accept referrals because that's the responsibility they've been given. You can't be given more responsibility, maybe more doctors, more equipment, a theater space, and not be willing to accept cases if you can or if it's within your capacity. So I'm not sure quite how to answer this question, but the important thing is to do what you can, anticipate risk, and try and reduce risk.
Absolutely. I think that there's no hand up. Any other question? We have about 7 minutes. Kindly put up your hand and then I'll ask you to talk. In the chat box as well, I think you've answered all the questions there. There's one from Mohammed that says, to add to Munira's question, if you are found in a situation where there is no specialist or MO or HO available, kindly stabilize the person and refer to the next point of care where such people are available. Thank you. So thanks, Mohammed, for your contribution. Great. Next one from iPhone says, please, is it okay for a specialist to ask a midwife referrer in a case without he first assessing it?
The ideal situation is that the person should see, at least. That's my thought. Yeah. That's the ideal situation.
Great. So I guess sometimes maybe just to get to know more about the case, the person may ask some few questions.
Yeah.
Hopefully it doesn't bring a lot of undue stress on the one who is sending the case, so that
Yeah.
it becomes problematic referring to that end.
Yeah.
These are more of human relations, and yeah. So those are all the comments that we have and questions that we have in the chat box. Anyone with any question, you can or contribution, kindly put up your hand, and then I will unmute you to go ahead. please electronically raise up your hand and then you have a go. We have 5 minutes to the top of the hour. Okay, so 2 more from the chat box from Dr. Joseph Mensa. Please, apart from the links provided, is there a WhatsApp page to get on to get these presentations? Yeah, absolutely. There is. Joseph, you can reach out to me if you have my number. I'll add you to the page as well. I don't know how to probably copy. Maybe the next time I will copy the page link and just put it up on the platform. But I'll try doing that right away. Whilst Dr. Sabi answers the next question from Yvonne Adai. Says, hi, Dr. Sabi, the case you had to do the hysterectomy for with no hysterectomy skill. How did you eventually go about it before referring to a specialist?
So I had assisted a number. I had, I think, probably done my side. So there are like 2 sides. So when you're learning, sometimes you do your side, but I hadn't done one independently myself. So it's not like I didn't know how to do it completely. And in that instance, the patient was bleeding quite a lot. It was, totally, the uterus was totally gone. Yeah, so I did hysterectomy for her. And that was the first time I did one.
Great. So I'll be able to put up the WhatsApp group that Dr. Joseph asked about on the page. Feel free to click on that link and then you'll be right on that WhatsApp group. Next is I'm putting up Dr. Sabi's evaluation, the Google Docs. I've put that up in the chat box. So kindly click on it and then you can provide the responses. It's also been put up on the WhatsApp group as well. I don't see any question in the chat box. Again, I don't see any hand up. 2 minutes to the top of the hour. If there's any comment, you have about a minute. Otherwise, then we can look at bringing this session to an end. So just on behalf of Ghana Medical Help, I would want to say a big thank you to Dr. Theophilus Ben-Sabi, who did a legendary job today, leading us with this presentation, quite concise, quite interactive, and I enjoyed every bit of it. I'm sure most of us have also done that, and we've learned a thing or two. That's the essence of these contributions and presentations that we do. It's our own small way of contributing to improving maternal and newborn care. We do this every Friday. Feel free if you want to join us in the presentation by leading us. We are glad to have you. You can reach out to me via the WhatsApp link I've just put up, or if you have my number, reach out to me. We are happy to have you. Dr. Gildas leads us with the obstetrics and gynecology component, all the other disciplines. I lead that. We cannot pay you for it, but we have just a token for you to get your credit. So usually we get about 500 Ghana cedi per contribution. Feel free if you're happy to contribute to the course without any much monetary benefit, but to improve upon health service delivery. Feel free to reach out and then we can have this done. Every Thursday for other presentations, Friday for obstetrics related presentations, and we are happy to take you. So thank you so much, Dr. Sabi, for the excellent, the legendary job done. Look, we've benefited a lot from this, and I'm sure it will shape the discourse. We'll put the video recording on the YouTube channel so that people can access it at any time they want to. I would also want to thank everyone for joining us today. It's a Friday, and like in Ghana, we say, thank God it's Friday. Lots of people have other things doing, but you dedicated an hour to join us to learn something new, to make a contribution to improve upon maternal and newborn care. We are grateful. Dr. Sabi, God bless you.
Thank you very much.
So we'll meet again next week. Have a lovely Friday and take care of yourself. God bless. Bye-bye.